Hello friends. So back to the videos after the hectic run up to the elections. So where I couldn't do few videos due to the code of conduct that was prevailing. So possibly this is the first video I'm recording after the run up to elections. So steroids in ICU, the rationale. So this talk I was meant to give in the Capricorn conference in Hubli that happened on 14th June uh, 2025 Saturday. So just trying to cover the conditions where steroids are sort of contemplated, and steroids is one of the favorite drug. So we look into, is there any evidence for usage of steroids in certain areas where one should not be using and where possibly there is some role. So the topics that I would cover, which is very contentious, is the role of steroids in ARDS. There's a separate video on this. You can go and watch it. But here I'll just very briefly run through the evidence because this is one area where intensivists would possibly need to have a bit of a clarity on the role of steroids. And the second important area where intensivists tend to use steroids is the sepsis. So we'll just very briefly look into the timelines of certain key studies where the role of steroids in sepsis has been looked into. The third important area where I find it little important is trying to avoid stridor in a high-risk patients with the use of steroids. And spinal shock, obviously, some of the neurosurgeons are very fond of using steroids in the spinal shock, despite all the trials pointing there's no benefit with the use of steroids. And even sometimes we see steroids being used in traumatic brain injury, which is again, I would say, is a malpractice. One should not be using it. And in polytrauma, surprisingly, there is an evidence called Hippolyte trial that is coming JAMA, which shows some benefit, although there are no compelling evidence to use it as a standard of care. Burns, of course, there is no use. Dengue, there is no use. And anaphylaxis. Anaphylaxis, there is a strong belief that steroids really help. But I'll just talk about how that helps to prevent the second phase response that happens in anaphylaxis. So these are some of the areas. So obviously there's a lot to be covered. So I'll try to run through a little faster. It was a 20-minute talk. So we look into steroids in ARDS. The whole enthusiasm for the role of steroids in ARDS, which was all sort of uh, not really put on an emphasis, came into forefront during the COVID time with this recovery trial, which we have to talk on. And with regards to evidence for steroids in ARDS, there are three trials and one meta-analysis. We'll briefly look into it. So very quickly running into this recovery trial that came during the thick of COVID in 2020 when a lot of deaths were happening. So large trial, 11,500 patients, 175 hospitals. It was a six-armed study looking into various drugs that were tested in COVID, like lopinavir, ritonavir, dexamethasone, chloroquine, hydroxychloroquine, azithromycin, tocilizumab, and plasma. And some of them were stopped. So we'll just look into the role of steroids. So 6,425 patients were part of the steroid study. They looked at 28-day mortality. They stratified these patients into patients who were mechanically ventilated. 41% of them were mechanically ventilated, 25% were on oxygen, and 13% did not need any intervention. They used dexamethasone 6 milligram per day for 10 days in 2,104 patients. And if you see, the steroids had maximal beneficial efficacy in 17% of the patients and reduced the death by one third. That was statistically significant. And it reduced 28-day mortality by one-fifth in patients who are needing oxygen, and that was also statistically significant. But the point to be noted is in patients who did not need any oxygen, there was no benefit. So in patients who are hypoxemic, who need oxygen, steroids were found to be beneficial in COVID, and we started using steroids in hypoxemic patients, and we believe a lot of lives were saved based on this particular landmark trial, which everyone should know. And the number needed to treat in mechanical ventilated to save one life was 8, and in patients needing oxygen, the number needed to treat was 25. And this is just a forest plot again to show the benefit of steroids in patients who need mechanical ventilation. As you see, the confidence interval is significant and who need oxygen. So that's about the COVID. So let's look into what was the literature that was available prior to the COVID. Even prior to the COVID, there were signals and pointers towards the benefit of steroids. And the landmark trial came from Meduri trial in 2007, randomized controlled trial, 5 hospital ICUs, Small study, 91 patients where methylprednisolone was used within 72 hours of ARDS onset, and 66% were having sepsis. Primary endpoint was to look at the reduction in the single point lung injury score and extubation at 7 days. So 91 patients, 63 were in the methylprednisolone group. So just pay attention to the dose. They used 1 milligram per kg per day for 28 days, and compared to placebo in 28 patients, they used placebo. So the reduction in lung injury score by 1 point happened in 69.8% in methylprednisolone compared to 35. So which means there was a significant reduction in the lung injury score in the methylprednisolone group. Extubation at 7 days happened in more number of patients in methylprednisolone group as compared to the placebo. And mortality was significantly less in methylprednisolone, and ICU length of stay also was lower in methyl. So basically, it was a very positive study suggesting immense benefit with the use of methylprednisolone in ARDS, and duration of mechanical ventilation also is lower, and the infection risk also. So it's a hugely positive study which basically said steroids really can do a magic with in patients with ARDS, and CRP also was lower at day 7. So this Meduris trial was the 2007 study, was the first study which showed some strong signal towards the benefit of use of steroids in ARDS. After this ARDS group came out with this particular study in NEJM RCT, where they looked at primary endpoint as 60-day mortality, secondary endpoint was ventilatory free days and organ failure free days. Here they had 180 patients, 89 in the methylprednisolone group and 91 in the placebo group. Just pay attention to the dose. Here they used higher dose, 2 milligram per kg, followed by 0.5 milligram per kg, 6th hourly for 14 days. And then they weaned it to 0.5 milligram per kg, 12th hourly for 7 days, and tapered and stopped. So 89 in early methylprednisolone. When they said early, so they stratified patients where early methylprednisolone was used when they used within 7 to 13 days after onset of ARDS, and placebo 91. But there was no difference in mortality, and 180-day mortality, there's no difference between early methylprednisolone and placebo group. And when they took the patients where methylprednisolone was used after 14 days, they found that 60-day and 180-day mortality was significantly higher when they used methylprednisolone later. And mechanical ventilation and organ failure 3 days also was higher. So, and infection risk, there was no increase in the infection. So basically, this sort of gave a clear pointer that use methylprednisolone early possibly doesn't have any great benefit, but if you use late, the 60-day and 180-day mortality significantly increases is what was shown in this particular study, which basically negated the positive signals that came from the Meduris trial. So after this, then this meta-analysis came where they took all the, see, if you look at this first one, it's the cohort studies. They took 5 cohort studies of 307 patients, and they took 4 randomized control trials. Independently, when they stratified and looked mortality risk, there was no difference. If you see the confidence interval, there was no sort of a benefit in cohort study nor in randomized. But when they mixed cohort studies and randomized control trials, and they did a meta-regression analysis, they found that steroids did show signal towards reduction. It was a statistical jargon they did by taking heterogeneous studies. Like initially, if you put cohort studies and compare, and RCTs and compare, there's no benefit. But when you combine cohort and RCTs, they showed there was a statistically significant reduction in the risk of mortality. And so basically, they also showed that there was increase in the number of patients who were weaned off the ventilation, and the duration of ventilation also was significantly less. And this is the forest plot of this particular meta-analysis, which showed some benefit when you combine both cohort studies and randomized controlled trial, and duration of mechanical ventilation also. They found favorable outcome with the use of steroids, and even the MOD score was better. So those were all the earlier studies. And during the thick of COVID, we saw the recovery trial which showed benefit with steroids. And during the same time, this particular study from the Spanish group came in Lancet by Villar et al., where this was in non-COVID patients, the use of steroids. They looked into multicentric randomized control trial in 17 ICUs. So they took moderate to severe ARDS where PaO to FiO was less than 200, on FiO to more than 50 with peak more than 10 at 24 hours. So here they used dexamethasone 20 milligram. If you look if you try to look at the equivalent dose of dexamethasone of 20 milligram, it comes to 106 milligram of methylprednisolone. So you can roughly take it as 2 mg per kg for a 50 kg or 60 kg. It would come to around 2 mg per kg of methylprednisolone. So day 1 to day 5, they use 20 milligram of dexamethasone, after which they wean to 10 mg once a day from day 6 to day 10. Primary outcome was to look at 28-day ventilatory-free days, and secondary outcome was to look at 60-day mortality. So they had 277 patients, 139 in the dexamethasone group, 138 in the control group. And ventilatory free days was higher, which is good in dexamethasone group as compared to the control group. That was significant. It means steroids had a significantly beneficial role. And, and this study, which came the thick of COVID, looking into the dose of 20 mg dexa in non-COVID ARDS, 60-day mortality was significantly less in DEXA group as compared to control group. There was no difference in the serious adverse events between these two groups. Of course, hyperglycemia was little more, not significant. Risk of new infection also, there was no difference between dexamethasone group and control group. And the need for prone ventilation was significantly less in dexamethasone group. And SOFA score was lower. So it's a hugely positive study which came in the thick of COVID in non-COVID ARDS. 20 milligram of dexamethasone showed significant benefit in reducing mortality, reducing the need of proning and increasing the ventilatory free days. And PaO2 and FiO2 also was higher at day 6. That's the Kaplan-Meier curve. So basically in discussion, so they did a subgroup analysis. Even when they looked at death due to multi-organ failure was significantly less in the dexamethasone group as compared to the control group. So some of the strengths of this study was it was the largest randomized controlled trial. There was no bias. And so they looked into all these types. So they basically said this study was a sort of a robust study. After all these studies, after the COVID vanished, 31st March 2023, this particular paper came in NEJM of the role of use of hydrocortisone against steroids in severe community-acquired pneumonia called Cape Cod trial. So I won't go into the details. This study, there is a separate video on this. So they have shown that hydrocortisone lowers the risk of 28-day death in patients with severe community-acquired pneumonia. So all in all, if you look into the evidence, so between COVID ARDS and non-COVID ARDS, we have pretty much concluded there is no major difference. So it means recovery trial findings can be applied for non-COVID ARDS. There are 4 good trials and 1 meta-analysis shows signal towards benefit of steroids in ARDS. And all these studies have used variable dosage of steroids and the type of steroids. Methylprednisolone was used in 2 trials at the dose of 60 to 120 mg. Dexamethasone was used in 2 trials, the dose of 6 to 20 mg, and hydrocortisone was used in 1 trial, which is the Cape Cod trial in 1 trial. So this is the sort of a body of evidence that we have at this point of time, and hydrocortisone was used in 200 mg. So what I can say at the end of it is all the sort of studies point towards some role of steroids and having some beneficial role in ARDS, and possibly they are here to stay. So we'll just jump the guns and look into what has been the body of evidence with the role of steroids in sepsis. So here I would sort of try to curtail it to lesser number of evidence and try to have a concluding remarks on this. So we look into the timeline. So the first role of use of steroids in sepsis came from this Corticus trial, which was from an Israeli group published in NEJM. So this study came out in 2008, where this study was done over a course of 3.5 years, and the number of patients they recruited was 499 patients. After this, the VAST trial came by the Canadian and the Australian New Zealand group in 2008. The study was conducted over 5 years in 778 patients. After this, Anan et al. French group came out with a study in 2009 with meta-analysis and a study conducted over 3.5 years in 299 patients. After that, Anan et al. In 2018, almost after 10 years, came out with this approaches trial, which was published in NEJM, where the study was done in 6.9 years, including much higher number of patients, 1,241 patients. So the latest steroid trial was the adrenal trial, which came in 2018 by the Balavenkatesh group from the Australia, which was done over 4.1 years. And this is the largest study where they looked at 3,800 patients. So this is the body of evidence when you look at the role of steroids in sepsis. So I can't go through all the trials due to the lack of time. So I'll just touch about what the body of evidence is. When you look at Corticus trial, This was more a detailed study, 499 patients, where they gave ACTH and saw the rise of the cortisol levels, and they stratified the patients into ACTH responsive and non-ACTH. And this study was happening when I was in Australia as well, where we used to, not the study, we used to do this practice. So they had 233 patients who did not have ACTH response, and they saw when they compared with hydrocortisone and placebo, the 28-day mortality was no different between these two groups. And they took the patients, 266 patients who had ACTH response, which means you give ACTH, there was a rise in the cortisol. And these are the patients where they felt the role of steroids would be helpful. Even there was no mortality benefit between hydrocortisone and placebo. But what they found in patients with ACTH responders, where you give ACTH, there is rise in cortisol. The shock reversal was better with the use of steroids, and the infections were more in hydrocortisone group. So that was the evidence. And when I was in Australia in 2000, sort of a 5, 6 and all, we used to use this ACTH, look at the cortisol. If they respond, we used to give hydrocortisone with the belief that it will do the shock reversal. So now all this has become obsolete. Then they did a meta-analysis again by Anand et al. Published in JAMA, 12 trials comparing corticosteroids and placebo. This meta-analysis showed that mortality was significantly less when in the group which used corticosteroids, and corticosteroids seemed to have benefited in patients who were more severely ill, and patients who were less severely ill, it was found to be harmful. And the Canadian group did another meta-analysis with 6 RCTs, and they found there was a conflicting sort of a results that came from a meta-analysis from the French group, where they said there is mortality benefit, but the Canadian group, when they did meta-analysis with 6 RCTs, they did not show any mortality difference. And on the problem with all this meta-analysis was there was publication bias, increased heterogeneities, but what all studies consistently showed was a shock reversal. So the take home, so even the adrenal trial did not show mortality benefit. It showed signals or trend towards the shock reversal or weaning of vasopressor. So what we can conclude is corticosteroid use have absolutely no mortality benefit in septic shock, but it has shown to help in shock reversal. So we have to think of using corticosteroids only in patients not in sepsis, who are in septic shock needing vasopressors, with an intent that we'll be able to wean off the vasopressors. Corticosteroid should not be used in sepsis where there is no shock. So there is no role for the usage of corticosteroids in patients with sepsis who are not needing vasopressors. So that is the take-home message for sepsis. So we'll jump the guns, look into what is the role of steroids in preventing the stridor in high-risk patients. So this is the sort of a uh, the summary of all the studies we have with regards to systematic review. 7 prospective randomized controlled trials they have looked into, where corticosteroids was used in 949 patients. And what did the systematic review show? That the reintubation rate with the use of pre-extubation usage of steroid, reintubation was prevented in a significant way. As you see, the confidence interval is significant. So 28, the number needed to treat was 28. And even the stridor reduction was found to be significant with the use of steroids in patients with high risk. And as you see, it was statistically significant. And in patients who are at a risk of reintubation, who are at a high risk of reintubation, the effect of the use of steroids was more pronounced. That was statistically significant. But in patients with a low risk for reintubation, there was no benefit with the use of steroids. As you see, confidence interval is not significant. And in patients who you deem as low risk for stridor, steroid did not have any benefit. So summarily, if you ask me where I use steroids in patients, especially in polytrauma, and the studies have shown in patients with polytrauma, with traumatic brain injury, these are the patients who are at a risk of stridor post-extubation. So if it is a polytrauma I'm extubating, I tend to use steroids before extubation to minimize, because these are the patients where the studies have shown they're at a higher risk of post-extubation stridor. So using steroids 4 hours prior to extubation has shown to significantly reduce the risk of stridor, reduce the risk of reintubation in high-risk patients is what we can conclude. So conclusion is beneficial in high-risk patients for preventing stridor and reducing reintubation, and benefit seems to be maximum when you give 4 hours prior to extubation. Routine use of corticosteroids prior to extubation is so we don't need to use steroids for routine extubations of post-operative cases. So if you ask me, I tend to use more in patients where you're portending if there is a head and neck surgery or if there is some sort of a airway issues that patient has had or complex maxillofacial surgeries where you would expect some sort of an edema where the risk of stridor may be there or difficult intubation may be there or the risk of reintubation, one could consider using steroids. How about steroids in spinal shock? Because I still see some of the neurosurgeons tend to use steroids in spinal shock. There are a lot of trials. I'll just touch on the NASIS 3 study where they used methylprednisolone within 3 hours and compared the role of methylprednisolone for 24 hours, methylprednisolone for 48 hours, and tirzolide, they used another arm where tirzolide was used for 48 hours. Recovery was similar. So there was no benefit with the use of methylprednisolone. And they even looked at usage of methylprednisolone between 3 to 8 hours, where they used methylprednisolone for 24 hours, 48 hours, or tirzolide for 48 hours. Recovery, as you see, where methylprednisolone was used for 48 hours, between 3 to 8 hours after spinal shock, tended to improve motor function, but there was no functional recovery. When they looked at mortality and morbidity, there was no difference with the use of methylprednisolone either for 24 hours or 48 hours. And infections were definitely found to be higher. And spinal shock patients, they are paraplegic or quadriplegic, they are at a huge risk of infections. By using methylprednisolone, what you are possibly doing is further increasing the risk of infections, and which may sort of try to increase the morbidity. So let us look into, so there's no evidence for the routine usage of methylprednisolone even in patients with spinal shock. And what about all the societies? When you look at American Association of Neurological Surgeons, they do not recommend use of corticosteroids in traumatic spinal cord injury. And Canadian Association of Emergency Physicians, corticosteroids they suggest is a treatment option, but it is not a standard of care. And you look at the mother body consortium of spinal cord medicine, there's no clinical evidence that exists to definitely recommend the use of steroids. So most societies do not endorse the use of methylprednisolone in spinal shock, albeit I see many neurosurgeons tend to use this. So possibly this has to be curtailed or abandoned because there's no evidence substantiating it. And traumatic brain injury is a sacrilege if you use steroids because this is a huge Cochrane database review of 20 trials, 12,303 patients. So the use of corticosteroids, there is no mortality reduction as you see, and the infection risk does not reduce, and there is no significant change in the infection risk. And GI bleed also, there is no sort of a benefit. So basically, steroids have no role. So steroids should no longer be routinely used in patients with traumatic brain injury because there's no benefit whatsoever with the use of steroids. And what about polytrauma? Surprisingly, there is one trial that is coming in JAMA called Hippolyte trial, which is a multicentric randomized controlled trial in 7 ICUs by the French group, where they have shown benefit with the use of steroids in polytrauma. 150 patients, 73 in corticosteroids, 76 in placebo. If you look at the risk of hospital-acquired pneumonia and ventilation, they used a steroid dose of 200 mg in this particular study. So the risk of hospital-acquired pneumonia and VAP was significantly less in the corticosteroid group. Mechanical ventilation free days was more, which is good in corticosteroids. Hyponatremia, none had. In placebo, 7 had. Mortality, there was no benefit. So if you look at this study, there are signals that steroids may help in polytrauma in reducing the risk of hospital-acquired pneumonia or VAP. But when you look into recommendations, routine use of corticosteroids in polytrauma cannot be recommended based on this particular trial, one trial. So we can't use this as a standard of care, but someone polytrauma in hypotension, you want to reduce the risk of need for vasopressors. So maybe you can consider substantiated by this study saying that it does increase the ventilation free days. You could, case by case, you could exercise your discretion. So burns, strictly no. So the studies have shown it increases the infection rate and there's no role for the use of corticosteroid in burns. What about dengue? Because I see dengue with secondary HLH, you possibly may have to use steroids, but otherwise routine dengues, there is this Cochrane review from Thai group. four trials. So if you look at the mortality, there is no benefit with the use of steroids. As you see, the confidence interval is not significant. And this was a study that came from Vietnam, where they took patients 5 to 20 years and they used steroids within 72 hours. Here they took 225 patients. There are two groups where one group had zero point 0.5 milligram per kg of corticosteroids into 3 days. And the second group had, they used a higher dose of corticosteroids at 2 milligram per kg into 3 days. So they used steroids basically for 3 days. And recovery, there was no difference between low dose, high dose, serious adverse events, there was nil. Hyperglycemia obviously was more. Shock reversal also there was more. So basically, all these studies really tell you there's no benefit with the use of steroids. So when you look into the systematic review, there are 8 studies, 948 patients, 4 trials. There's no benefit for corticosteroids. So the the conclusion is there's no evidence for the use of corticosteroids in dengue shock syndrome. Anaphylaxis, we are very fond of using steroids, but if you look into the science, corticosteroid is used only to prevent biphasic, to prevent the recurrence of this anaphylaxis, the second biphasic response that tends to happen, but it is not useful to mitigate immediate reaction. And corticosteroids, even if you use in anaphylaxis, should be used only for 48 hours and stop. So recommendations cannot be made for the use of corticosteroid in anaphylaxis is what has been suggested based on Cochrane review, but one could substantiate its usage to prevent the biphasic response in anaphylaxis. Even if you use it, it has to be not more than 48 hours. So that's about it, friends, for the role of steroids. So I think for intensivists, the juice is in the role of steroids in ARDS, where there is signals towards benefit. And the second is in septic shock to do the shock reversal. Third is in extubation stridor in high risk patients. When I say high risk, it is mainly the polytrauma involving the face, neck, and head injury, where the risk of stridor is shown to be a little higher. Apart from this, in anaphylaxis, in burns, in traumatic brain injury, in spinal cord injury, there is no role for the usage, routine usage of steroids as a standard care. So thank you, friends. So I request you all to submit your valuable work to Journal of Acute Care, and you can visit my website to adhere to this lecture. Thank you. Thank you, all.